haven't met me in person, I'm a pediatric dermatologist who mostly spent her career seeing adults and a few children at Kaiser, and then I got my dream job to work at Rady. And as I worked at Rady, I started to see patients that were challenging because I didn't really have a lot of background in how to deal with them. So I called my talk Gender and Dermatology: A Beginning, and you see the cup of coffee is steaming, or the tea is steaming, so go ahead and get your beverages ready. So I don't have any disclosures, but I want to say that I have made mistakes. I will probably make some mistakes in the presentation today. It's always hard to say the correct things all the time, and things are constantly changing. So if there's some egregious mistake I make, please speak up in the chat feature, and at the end, I'll be happy to address those comments. I'm showing you this picture because this image takes me back to 1975 when I was a first-year medical student at University of Michigan. We had a psychiatry lecture rotation. Imagine a tiny conference room crammed with 250 medical students, 75% of which are male. And from the back of the room, excited whispers start as a extremely glamorous, tall woman with long cascading hair, a tight dress, bright red lipstick, and very high heels, sashays down the aisle and assumes a place at the podium with the psychiatrist who is speaking. As she walks to the front of the classroom and mounts the podium, the men are all whispering excitedly, and some are saying things like hubba hubba and baba boom. And then one of the men next to me excitedly whispers, "That's the neurosurgeon's secretary." And I'm, it's a woman coming up to the stage. I don't really understand what all the fuss is about. And it's like a big balloon swelling with excitement. And then suddenly somebody puts a needle in the balloon and it pops loudly as the professor announces that this person is what we would now call transgender. The disappointment among the men was palpable, and many angrily muttered that they felt cheated or lied to, because I guess they may have felt that this was somebody very desirable, but once they found out that the gender that the person represented was not the gender that they were born with, they lost interest and were disappointed and deflated. So you can see this image from a recent copy of Vanity Fair magazine with Caitlyn Jenner, who's a very notable transgender person. And you can see the glamour in this photograph. So when I see patients, or when I even go about my daily life, I have to consider a lot of what's called intersectionality. So as you hear me talking today, I'd like you to think about what these intersections are when you encounter a patient. What about race? What about gender? What about sex? What about economic, social, and educational class? And this is the only slide you're going to see today that shows arrows. There's something called word cloud, and I wanted to have a theme for this talk, so I took my entire presentation and downloaded it into word cloud. And this is the picture that emerges, and you can see near the right side of the heart next to the red gender, you could see UCSD. So UCSD is a very important part of how we take care of patients. In this image, you can see a mother standing next to a child, and she's holding a big sign that says, "I love my transgender child." This picture has very special resonance for me because I have an adult transgender child. So my motivation for learning about this not only extended to my patients, but my own family. And you can see that when you talk about transgender diverse kids, and I'll define this for you in a few minutes, but just children that identify with gender differently, even in kindergarten to 8th grade, 54% verbally harassed, 24% physically assaulted, 13% sexually assaulted, and 17% quit school due to maltreatment. Those are the children we're seeing in our practice, and those are the adults that are scarred by their childhood experience. So as we talk, I'd like to remind you that gender terms are not diagnoses, they're descriptions. This is the image of Dr. Rachel Levine. She's the Secretary of Health for the Commonwealth of Pennsylvania. That's a description. She's a professor of pediatrics and psychiatry at the Penn State College of Medicine. That's a description. She's a very important figure in the Association of State and Territorial Health Officials. That's an important description. Another description of Rachel Levine is that she is a transgender physician. So what is gender? Think of gender as an internal sense, a conviction of how a person identifies. Sexuality is actually different. That is whom a person is attracted to. Remember that picture of Caitlin Jennings I showed you on the cover of Vanity Fair magazine? Caitlin Jennings Jenner started life as Bruce Jenner, an Olympian track specialist. And this really exemplifies that when you walk into a room and see a patient, the physical anatomy you or the patient presents to the world may be entirely different from the sense of self you carry inside. So this was Bruce Jenner, but this was Bruce Jenner inside. So let's talk about some definitions. Sexual orientation is a person's sexual identity in relation to the genders to which they're attracted. And as I said before, sexual orientation and gender identity develop separately. So what makes up gender? Of course, you have your genotype, which expresses itself. You have your phenotype, how you appear due to that genetic expression. So your gender identity is your sense of what yourself is. And your gender expression is how you present or show yourself to the world. So if you look at a California birth certificate, remember that when you go in the delivery room, as many of you have been, and somebody says it's a boy or it's a girl, or sometimes, kind of shockingly to the group, it's you have a lovely, healthy baby. We can't tell you the gender because that's an intersex child. So it's a sign at birth, usually from an inspection of the genital anatomy, and can be assigned even before birth from various procedures. And as of 2 years ago, the California Department of Public Health has issued a new birth certificate which has a gender of female, male, non-binary, which I'll define for you in just a moment, or just blank, according to the receipt of appropriate documentation. And the most important thing here is no provider attestation required. So if someone wants to change their gender, they file the appropriate paperwork with the Department of Public Health and get a new birth certificate. So think back to your youngest memories and think back about, in the 1950s, it's, I want to play with that doctor kit. No, that's for boys. Girls can play with the dollhouse. And of course, that's completely on its head now. But imagine that children at the age of 2 years recognize two genders. And at the age of 3, they have what's called stereotype behavior congruence. That means that if you identify as a boy, you're going to play with the truck. If you identify as a girl, you're going to play with the little kitchen set. When I gave birth to twins, when my older daughter was 3 years old, there was a little boy named Derek that used to come and visit our house. And I would watch him and my daughter and then breastfeed the twins in his presence. So my daughter Becky had no interest for her doll, but Derek was very interested in the doll. And one day I saw him playing with Becky, and he was nursing the baby doll from his chest. I just thought that was the sweetest, most beautiful thing. So that shows you that you can defy stereotype behavior congruence. And if you model behavior, children will be paying attention. So what is gender identity? It's that deep internal sense, and it comes from many different factors, from your biology, from your environment, from your self-understanding, and your cultural expectations. It can be fluid. The average age of children who later recalled that they had they were trying to identify, like, when did you have that feeling that your gender identity was different than how other people saw you? About 8.5 years. And then 10 years later is when they said something about it. But this is happening earlier and earlier. I saw a 5-year-old at Grady in the past year who already knew at the age of 3 their gender was different. And they had that appropriately noted in the EPIC chart, is the birth name is this, but the patient wants to be called this. And then in the population, if you think about what is straight and what we'll define as cisgender, which just means basically straight, 20% of millennials and even 7% of my generation, boomers, identify with something other than that. And I love this picture of the police officers in Toronto decked out in all these bright colors, because they're probably closer to boomer than millennial. Why am I talking to you about this today? Because you as a dermatologist may have a tremendous impact on the lives of transgender individuals who seek to realize their gender identity. And we'll talk about the ways that you can do that. So first of all, let's talk about how the person looks when they walk in the room. That is their gender expression. That's their clothing, their hair, their manners, some of the activities. They may come in a soccer uniform or wearing a cheerleader outfit, and their social roles. And I love this picture because my daughter's fiance is a woman who often dresses like this. And what happens when this person tries to use a ladies' room? What happens when this person is nervous about going in a men's room? So this big controversy about bathrooms boils down to how others see you. And the big fear that some people have about people using the wrong restroom is that they're going to try to sexually recruit people to whatever their evil scheme is, which is completely ridiculous. They just want to use the restroom. So cisgender is the most common gender choice, where a person identifies and expresses the gender that's consistent with the culturally defined norms of their sex assigned at birth. And then transgender and gender diverse, which will be referred to as the abbreviation TGD, is the gender identity or expression differs from the sex assigned at birth. And if you imagine in the population of 150,000 teenagers identifying as transgender, I think that's likely an underestimate. And 0.6% of US adults, likely an underestimate. And this includes trans men, men that started out genetically, phenotypically as women, and trans women and others. And this is a comic book called The Marvel Hero Project. So you see this young, phenotypically female featuring the mighty Rebecca. And the mighty Rebecca is a real person. And the Marvel Hero Project finds children and teenagers who are real heroes in their communities. And she is an activist for transgender rights for children and teenagers. I love this picture. This is a picture of gender diverse people because we're in a unique environment in San Diego. This is a little microcosm of a place where people who dress like this are more likely to be accepted and not treated any differently than people who dress like 1950s situation comedies. So the difficulty is when you dress like this, but you go to a community where people like this would be bullied or abused. And gender diverse simply means that the appearance and behaviors are incongruent with the birth sex. And so if you're using the word gender nonconforming, you now want to use the word gender diverse. And then there's agender, and that's a person who doesn't identify a particular gender. How do you know these things are catching on in society? When the British superstore, Selfridges, loves, and it's always this we, 10 reasons why we love, like who is we? But it's, the advertising people at Selfridges. Why do they love this? Because they could sell really expensive clothing to people of multiple genders, and it will be comfortable to wear. This is another very famous physician from my era. This is Renee Richards, who started life as a male ophthalmologist in New York. And about the time I graduated from medical school, Renee Richards was a wonderful tennis player at Yale and became a female tennis player using a different name, but then the press caught up with her, and there was this furor that continues to this day about our people who are transgender, male to female, kind of cheating because they have bigger bone structure and better muscles. But this was another famous personality who was assigned the male sex at birth. So sometimes we call people male to female, affirmed female, or trans female. And then the gender identity or gender expression is more what you'd consider traditionally feminine. And then trans male, I think many of you recognize this picture of Chaz Bono, who started life as Chastity Bono, the son of celebrity parents, now, whose gender identity or gender expression that's asserted to be more masculine, female to male, affirmed male, or trans male. You'll see FTM and MTF in medical records more than affirmed male, and sometimes you'll see the trans. Gender dysphoria is a clinical symptom. So you can put a symptom like, when you put in your diagnoses in your note, a cough, that's a symptom. It's not a diagnosis. So here's a picture from the internet of what looks like a traditionally feminine face, hairstyle, and makeup. And this child is holding a card that said, I never had many friends. I didn't fit in with girls, and the boys made fun of me. And I can even remember in my second grade class, there was a boy who seemed kind of like what we would call then a sissy. The boys didn't want anything to do on the playground with him. And he would chase after the girls trying to kiss them, and they'd all run away from him. And again, we recognized that something was different, and he was bullied for it, but we didn't really know what it was. So dysphoria just means a kind of an ill feeling or I kind of think of dysphoria as I get off a whirling ride and my head is whirling, so I feel dysphoric. But it's actually an alienation to your own physical characteristics or the social roles of your assigned gender. And this is a psychiatric diagnosis in DS5 and ICD-11, but it's really a symptom. And we're no longer using the phrase gender identity disorder because it's not a disorder, it's a different feeling. So the World Professional Association for Transgender Health, the website is wpath.org. So when we beat a path to seeing our patients, we can start with a wonderful resource. So if you're wondering, like, gosh, how do I approach that patient? What do I offer them? And you're looking for guidance, this is a wonderful free resource that's available to you. So how do we start when we're seeing patients? It's what's up front that counts. Remember, the people at the front desk are setting the tone for the interaction. So it really begins with teaching them how to approach patients. So instead of saying, "How may I help you, sir?" say, "How may I help you?" And if the receptionist is talking to another receptionist saying he's here for his appointment, or they're calling you or calling the back office, you can say the patient is here. Instead of saying, "Do you have a wife?" you can say, "Are you in a relationship? And what are your mother and father's names? What are your parents' names?" Now remember, up front, the patient and their family is not sure if they can trust you or the people up front. So maybe they're not going to give the answer. As we all know from medical school on, sometimes it takes 2, 3, 4, 5 people asking you the question to finally get the answer that's going to help you with the patient. I show this image of 2 women, one who looks a little bit older and one who looks a little bit younger, and have the title "Leave Your Assumptions at the Door" to tell you about an interaction I had about 10 years ago. I walked into a room. I knew the patient's approximate age and their history, even though I hadn't seen them before from looking at the medical record. And it was a younger looking woman accompanied by an older looking woman. So I walked in, introduced myself, and looked at the younger woman and said to her, "Oh, you brought your mother." And she said in a stony voice, "No, this is my partner." Immediately, I took a deep breath and said, "Okay, I'm going to start again. Let me go out of the room and come back, and let's do this again." I walked out of the room, came back in the room and said, "Good morning, Ms. So-and-so, and who's with you today?" And she said, "It's my partner." And we all started to laugh. So yes, you'll make many mistakes along the road, but if you keep a sense of humor and a sense of dignity and you beg forgiveness, most of the time you will have a better outcome than if you kind of try to soldier forward. So one of the things in my approach to patient visits is to use a gender-affirming care model, and remembering that in these situations, and remember, this is not only a gender-affirming care model, but this might be a class-affirming care model, this might be a race-affirming care model, because in any situation where the patient feels like they may be bullied or even kicked out of the office because I don't take care of those people, they're kind of shy and fearful. So a lot of times, and you see in this image that there's a patient who appears to be female sitting on an exam table and a doctor who appears to be female just talking to the patient. Will often grumble, "Oh, didn't they tell you to put on a gown?" But remember, some people are they have to kind of check you out and see if they're even going to trust you to see their body. So use the moment to say, let's get to know each other and talk a little bit. I'll step out and let you get undressed, and then we can talk. I can have a look at you. And here's what I'll be looking at today. How do you let people know, even before you physically lay eyes on them, that you're going to care about them? And having a button that you, or a little sign or a little picture, you know how the Secret Service all wear these flag pins in their lapels? You can have a little rainbow pin or a heart, something that tells you that you care. And it's very interesting, as I was putting this talk together, I did not find these signs in multiple languages, but that doesn't mean we can't have them. It'd probably be a good idea to have this in 3 or 4 of the most commonly used languages so that people of all languages will understand that we care about them. So this is from the literature, and these are questions that can be asked in a dermatology clinical setting. What is your sexual orientation? What is your gender identity? What name and pronouns? Oh, pronouns. I am constantly screwing up with pronouns and asking forgiveness. So he and she, they is the word of the year. And to me, they always implied more than one person. So if I talk about people in my family and I say they, it's not clear if you're saying one person or multiple people. So you have to make that clear in the next sentence. And then you'll hear these other things like Z, here, here's, I, ears. And you'll also see this prefix. And I've seen it in the New York Times now, MX. I like it because it sounds mysterious. It's a gender-neutral honorific. So while we're trying to figure out what pronouns people are using and how to talk to them, we're also going to now explore the age-related approach to patient care. Children, tweens, young adult, and older adult. I love this image of this child who has medium length curly hair, earrings, and what looks like a school uniform with a white shirt and a tie, because this is not a gender specific photo. So when you know that you're going to be seeing a child who expresses gender differently, you want to make sure and value that child for who they are at any age, even a 5-year-old. And it's very important with these patients to be interested and also to say to them, frankly, you know, this is new territory for me. And I know because it's your family and the way you do things, you probably know more than I do. So if I say something wrong, don't hesitate to interrupt. I'd like to learn from you, and I'll be glad to support you, but I'd like to hear from you what you think that I need to know about you. These children are at increased risk for bullying, violence, and suicide. And this starts young, but goes through the entire age spectrum. When I started out in pediatrics in the 1970s, it was watchful waiting. Oh, that 3-year-old boy that likes to wear a dress, just, you know, he'll get over it, you know, let him play at home, but don't let him out of the house dressed like that. So even children who are prepubertal and transgender diverse, they know their gender as well as their cisgendered peers. So you want to start supporting them right away. And at Rady Children's, we have a wonderful center for gender affirming care. As you can see by this slide, there are many services that are available. And there's even a handy clickable link so you can make an appointment in dermatology. And you can see there are many things that you need to provide when you're doing gender affirming care. There's going to be hormone treatments, there's going to be reproductive health, surgical specialists, legal name change, resources, mental health support, voice therapy. I remember my son going through voice therapy and doing exercises to make an appropriate voice. Ongoing education. And then we go from the children to the tweens who are still being supported at Rady. And one really important thing to know, and for those of you who are taking boards, is that the gonadotropin releasing hormone analogs are important to use to allow time for decision making and to delay puberty for a couple of years. It really does help with self-harm and suicide prevention because there's lower odds of those things happening if puberty is temporarily suppressed. But there's a problem also with decreased bone mineral density. And it's really unknown right now if there's going to be a catch-up if puberty starts. So these children will need to experience sex hormones at some point, probably not longer than 2 years after they start on this hormone suppression. And then for teens who want to present or appear as the gender that they would like to express, there are questions about hair, clothing. You'll see people with breast development wearing these very tight, restrictive garments. And dermatologically, you may see irritation, urticaria from this tight compression. You could see these look like undershirts, but you see all those clasps there, and those things are really snug. And those are called binders. And those can have, like I said, dermatologic complications. And then legal affirmation, medical affirmation, which is going to be hormonal suppression. And remember that if you have female reproductive equipment, despite your hormonal suppression of your menses, you can still have unplanned pregnancies. And we'll talk about that a little more with isotretinoin. And then you're starting to talk with teens about surgery, but you, for the most part, want to wait until they're really reached their maximum growth before you start surgery. As dermatologists, we're rarely called upon to prevent a suicide. But I think we should take a much more active role in talking to our patients about this because we are physicians and we care about them. And often we're seeing them more than their primary care doctor may be if we're treating some dermatologic aspect. So the MA at Rady will ask if the child's been down, depressed, or irritable for 2 days or more, if they're losing pleasure in activities for 2 days or more, and if so, an elaborate questionnaire opens up and populates the after-visit summary with recommendations for care and follow-up, and which you will also verbally iterate to the patient. So it's very important that you have the perspective to start from the early teenage years and continue for a lifetime. It's very important to remember that transgender women, male to female, have the highest percentage of new HIV infections. And often they don't know their HIV status. So consider screening these patients for HIV and STDs. You're supposed to get a hepatitis and HPV vaccination in childhood, but this could continue for a lifetime if you haven't. And now's the time to start considering HIV pre-exposure prophylaxis. Now, if we go from Rady to UCSD, I don't have the direct experience of caring for patients in the UCSD system. So I'm going to talk to you more from my standpoint of what I've learned, rather than what people are, what you might be doing in your practice at UCSD. So once you have that young adult patient in the EPIC EMR, Patients can document their sexual orientation and gender identity at MyChart. And somehow, which I haven't personally seen, there's supposed to be a place where you can put information about sexual organs, hormone use, and information that's private and can only be accessed by the medical team and staff, and quality improvement if needed. And then finally, let's not forget older adults, since I happen to be one right now. And remember that sexual and gender expression is lifelong. Shockingly, increases in HIV in people in age over 60. So do not ever forget to screen these people for HIV, STDs, hepatitis, and HPV vaccination, even at an older age. And again, HIV pre-exposure prophylaxis. Now let's talk in the last 20 minutes that we have left about gender affirmation and dermatologic care. You can see this image of two what look like women sitting on a beach. They're in Australia, and they have these deep tans, and this is not makeup. And the reason I put this picture here, there's two reasons. One is that my lifelong passion has been to try to prevent and early detect skin cancer. So obviously they don't share that passion. But the second is that you make the assumption by looking at the picture about what their lifestyle is. These women were on some bachelor show in Australia. They were actually in a lesbian relationship, but they still felt that they had to maintain this appearance in order to be successful. So I'm going to talk to you briefly today about what to do if you have patients in this situation with acne, patients who have too much hair or not enough hair. Very briefly about cosmetic procedures and filler frenzy, and finally about skin cancer risk. So addressing hormonal therapy, male to female, people are going to be taking estradiol and anti-androgens such as spironolactone and using cosmetics to achieve the appearance they would like. So using these treatments, they're going to have increased fat deposition on the face, chest, breast, hips, and buttocks. The scalp hairs might improve in density and texture. Acne can improve, but they do have a little decreased sebum production, so they start to get a little asteatotic eczema, xerosis, and pruritus. And I love this picture. This is an image of cosmetic procedures, male to female, because in both pictures, the hairstyle is about the same, but you can see the subtle changes that give you a more female appearance by the eyebrows, by the areas where you do neurotoxin injection and fillers and possible rhinoplasty. So this is Dr. Ortiz's area where she can assist your patients in achieving this appearance that you like. This is an important aspect of the female to male experience with androgens. They do alter the physique so that you get increased subcutaneous fat loss, and you get male pattern hair growth, and you can have alopecia months or years after you start hormones, as well as the obvious hypertrichosis. It will inhibit menstruation and worsen acne. And here you could see the female to male in the cosmetic procedures, and you can see the areas indicated by the dots where you can use neurotoxin and fillers to achieve a more traditionally male look. Now, one problem when you're on testosterone therapy for women to men is that the cumulative incidence of acne will increase. And you can see that I've circled on this bar graph that at 24 months, almost 40% of the patients will have acne. So they will be coming to you for this. And this is an image showing that transgender men with testosterone have this 52% increase of chest acne compared to cisgender men who only have a 6.7% increase in acne. I pledge, the bane of my existence. So the AAD does have an I pledge work group. And in this work group, they are trying to make a new system because currently all patients have to register with iPledge. And for those few of you listening who don't know what iPledge is, it is a government mandated program to be able to prescribe oral isotretinoin for acne. Some patients may refuse to register as a sex, which they don't identify. Also, once again, not to forget, when you're prescribing, you must understand the patient's reproductive potential. If you are a female to male, if you have a female to male patient with an intact female reproductive system on topical or parenteral testosterone, they can get pregnant. So the proposed system is going to be to identify persons who can register as they can get pregnant or they cannot get pregnant. Unfortunately, with the current political administration, the FDA is not interested in pursuing this, even though the iPledge program company that administers it would be willing to make the change. So I learned something interesting about topical bimatoprost, that it could actually enhance eyebrows too, because I know that I've had disappointing results with using it in children with alopecia areata, but apparently it's helpful for female to male to improve eyebrows. Also, if you have a male to female patient using minoxidil hair transplants or finasteride, would be safe to use with estradiol and spironolactone if the baseline PSA is normal. And then female to male testosterone, as you know, can trigger androgenetic alopecia years later. So over the years in practice, I've been alone in a room with a male patient who has a genital problem. And we did have, for a while, the only male person in the department where I was working was a nurse practitioner. And so the patient would kind of not be undressed and be hesitant. And I'd say, oh, I can get Ted and he can examine you if you'd like to see a nurse practitioner. And then almost invariably they would say, no, that's okay. I'll let you look. Again, because there's that issue of trust, there's that embarrassment. Are you going to belittle them? Are they going to have an embarrassing situation while you're examining them? So I tell the patients that you saw the image earlier where the doctor is talking to the clothed patient. I say, it may be a little embarrassing for you, but I literally do not want you to die of embarrassment, because it's very important for me to look in these places. And oftentimes I have a mirror and I can show the patient with the mirror, here's how you look, here's what you want to check. And then they have a lot more confidence. And there are several procedures, vaginoplasty, where they're actually using the penile and scrotal skin to form a neovagina. So you can imagine that you have to have preoperative hair removal of these areas so you don't get postoperative urinary retention, obstruction, or infection. And also remember that this tissue is a hotbed for the possibility of condyloma, squamous cell cancer, and lichen sclerosis. So this repurposed tissue needs to be inspected. And then phalloplasty for female to male, where creation of neoureter and neophallus is from a limb skin flap. Again, not only does that limb have sun exposure, so that needs to be checked, but it also has hair, so that needs to be removed. So here's the problem with hair reduction. First of all, there's no direct comparison between laser and electrolysis. So there's no head-to-head, double-blind, let's do this half of you with laser, let's do this half of you with electrolysis. Maybe somebody would like to do that. So the World Professional Association for Transgender Health says that hair removal is medically necessary. And I think we all agree that it is medically necessary. However, hair removal is not specified as a tax-deductible expense for the IRS, but may fall under costs of gender affirmation, which is tax-deductible. And some insurers will cover it only if it's performed by a board-certified dermatologist or qualified healthcare provider. And the way that some departments get around this, I know that when I was training in Cincinnati in the 80s, in our department, we had a wonderful electrologist. And she came to meetings, she talked about electrolysis and how it works. And she was a part of our department. And then insurance is always a nightmare. There's no coverage for permanent hair removal in 95% of Medicaid and ACA marketplace policies. Some plans say cosmetic procedures deemed medically necessary could be used for hair removal coverage, but you may have to write a letter of medical necessity to an insurer. So here's where people end up crossing the border or doing crazy things in hotel rooms because it's cheaper and they're desperate to achieve that appearance. So maybe again, about 10 years ago, I saw a man, I was examining his scalp and he had these bizarre nodules in his scalp and some were draining. I said, what happened? He said, oh, I went to TJ for a hair transplant. And the way that they did a hair transplant was they took like Barbie doll hair, like plastic hair. They threaded it through his scalp and kind of knotted it. And it left behind these terrible draining scars and wounds. So I know many of you have seen the effects of people desperate to have that appearance and going to the illicit provider and having things like silicone, paraffin, oils injected into their bodies. And they have these terrible complications. If you see somebody who looks like they have these and maybe they're embarrassed or ashamed and they're not forthcoming, if you gently work with them, you may be able to find out that they did have this, and then you'll have a better way to proceed to help them. These foreign body reactions, infections, the migration material, which can be fatal because you can get these foreign body emboli with stroke and pulmonary embolism. So just add that to another list of things that cause chronic ulceration. Not only is it something like T-cell lymphoma, but it can be that you're injecting strange things into your body to try to look the way you want to look. And then finally, this is just breaking news, skin cancer risk, gender, and sexual orientation in a huge survey of 845,000 people in the United States. So they broke it down into two different papers, both written by first author Singer, of gender and sexual orientation. So the cisgender men and women, the transgender men and women, and the gender nonconforming. The gender nonconforming had the highest rates of self-reported skin cancer history. Now, these are people in their 40s on the average. So I think that as this population ages, it's going to be even higher. And then, of course, the gender nonconforming people had less access to skin cancer screenings and healthcare. And then as far as sexual orientation, gay and bisexual men had a higher self-reported rate of skin cancer, and bisexual men did the most indoor tanning. So now let's talk about how do we continue to learn about caring for people across the genders. So what is currently the curricula in general at UCSD? So LGBTQ health leaders and SOGI, which is the Sexual Orientation and Gender Identity Committee, are now training physicians to be LGBTQ competent, meaning they are culturally competent and experienced with specialized types of care, such as transgender surgeries. I was just in touch with one of the people on this committee, and I'm sharing my materials with her. Because of coronavirus, they really aren't able to move forward with this initiative as much as they would like, because they all have these other obligations. But they eventually, I think they're interested in putting together a comprehensive care plan that would include something like the Rady model. And then if you just look at curricula in dermatology residency programs, and you look at the people that SGM means, people that have sexual gender minorities. And 80% of program directors said it's really important or somewhat important to get this information, but there's 0 hours devoted to training in 46% of programs. So now you've had your hour. So now we fall into the other 54% that had their training. This is just a drop in the bucket. This is just a beginning. This is just to help you open your eyes and understand how much there is to learn. There is an American Academy of Dermatology expert resource group on LGBTQ and SGM health. I advise you to try to get involved in that. In order to provide the best care to patients, curriculum reform, that's why I mentioned that there might be a board question about the use of gonadotrophin release hormone suppression in tweens and teens. Exposure to patient-centered, welcoming, and respectful environments. And again, to show that we welcome people, we should have some little signage, logos, things that we wear on our own uniforms. And then the most neglected aspect is to promote an institutional environment welcoming healthcare professionals who identify differently. So in summary, the gender jigsaw is undeniably complex, but understood better and assembled properly, it can be undeniably beautiful too. So there are resources that I'm now showing on the screen. And what I'd like to do is take this presentation in outline form. You will be able to have these resources as your one-stop shopping for the beginning of your lifelong learning. So these are all organizations that are going to be helpful to children, teenagers, your patients. I want to call out a specific book called The Gender Book. When I first found that my son wanted to be my son, I went to a library and just started pulling books off the shelf. This was the first book that I found, and it's such a wonderful book that I now have a copy of it. And when we are able to do things like this, I would be happy to lend this copy to anybody who would like to read it. And then the references to the talk are here. And now I'd like to open up to any questions if you want to go ahead and chat them. Thanks for being a great audience.
Thank you, Dr. Boiko. That was a wonderful talk. I really enjoyed it. We really appreciate you coming to talk to us about this. We'll wait for some chats and questions, but in the meantime, I agree this is a really important topic, especially to include in residency education, which is something that we've done, and for example, we'll be having an upcoming journal club that's related to the topic. And I would invite, if you have time, any contributions to help us develop our curriculum on this.
And I'd be delighted to. And again, one of the things that is so important to me is that if you can genuinely show that you're interested, no matter what gender blunder, inadvertent mistake you might make, not only will your patients be very forgiving, but they will start to refer other people to you. So I can see that if we can develop this, our area is in crying need of people that can really do a good job and a safe job for patients. And especially in the cosmetic aspect, I think that far too long it's been either this is horribly expensive, I'm just going to go to TJ and get something, or how about, we can make this more affordable to you and let us show you how we can do it right. And let's be out in the community. Let's go to places where people haven't done skin cancer screenings before, and let's do them.
It's definitely an opportunity for us to contribute and get involved. There are a lot of comments, just a lot of appreciation. Thank you so much for the helpful talk and resources. Great talk, important subject. Thank you, thank you, thank you. And let's see, lots of appreciation and gratitude and thanks for this excellent talk. There are some comments. So one comment from Dr. Marsh, she wanted to mention that one of the UCSD medical students did a survey of derm program records and also found similar statistics, which include that only 40% of programs have an LGBTQ specific curriculum. And she mentioned she just ordered a rainbow pin. Thank you for the gift. Dr. Lightford, very interesting talk. The point about iPledge was very interesting. In my experience, talking about the necessity to register the patient as the gender of their birth has been a way to tactfully discuss the fact that they still are able to become pregnant if they are genetically female. Do you think this is the way to go about this?
Yes, absolutely. I think the difficult and humiliating problem is that when you start to get those iPledge monthly questionnaires, they're very oriented towards cisgender female. And there's really not an understanding that you can say to the person, you have the plumbing that can still be activated, even though you don't identify as female. So for the purposes of getting this needed medicine, we need to register you that way. Now, in my personal experience, since my son is male, if he needs isotretinoin and he changes his gender to male on all his medical records in the healthcare system that he's enrolled in and presents himself as male, and the physician that sees him doesn't look back in his record and he doesn't disclose it, he could get pregnant. So that's why it's really important when you're talking about isotretinoin to anyone is to ask them, like who's their partner and what they expect. Like I actually had a teenager who was sexually active on isotretinoin, and she was, and her family were wonderful about discussing this and discussing that she must not get pregnant and that she needed to have some kind of birth control that could prevent her from getting pregnant, even though she was going to be abstinent, because you never know in a situation what your emotions may overrule your medical advice.
Thank you. Dr. Romero comments, electrolysis is the main option for transgender patients with gray or white hair. Laser doesn't work well. And
yes. So I just wanted to comment, I did have a slide that I took out because I thought everybody would know that, but I'm glad Dr. Romero brought that up. It's not only the gray or the white hair, but it's also like if you have a lot of lanugo hair, laser will not be effective for that. So that's why it's nice to have electrolysis in a department, so we have that option as well as the laser being available.
And Dr. Kaufman mentioned this is especially helpful for us and our staff since we share a registration desk with endocrinology. Thank you. Dr. Yuen says thank you. She mentions her twin sister is going to do a fellowship in transgender surgery. Very important topic. And Dr. Lyford says thank you as well. Another question from Dr. Contestable. Does anyone have recommendations on local professional electrolysis?
I'm going to leave that open to the group because a few years ago, I tried to find a resource for electrolysis in children and teenagers. And Kaiser had a list of people that did electrolysis, but none of the people were familiar to me. And I felt a little hesitant about recommending people I didn't know. So maybe that would be a good thing for us to try to research so we could have that available to us.
That would be helpful. I've had patients ask me about that as well. Dr. Yuen was asking if anybody knows how many treatments would typically be needed in electrolysis. If anyone knows, please feel free to share. Dr. Boiko, are you aware?
It's more than 10.
Okay.
It's going to be like laser.
Quite a few. Okay. Any other comments or questions from the audience? Oh, we do have one. Dr. Romero mentions it's frustrating as the VA doesn't have electrology or maybe electrolysis or electrology, yes. And there is no community care electrologist signed up with the VA to be able to refer these patients and have VA coverage. There is an American Electrology Society where there is some regulation in their training and safety practices. I did not know that. Thank you. That might be a place to start to see if there are like a local listing.
I think this is also a great way to think about if we know somebody who's maybe already an RN, but they're looking to branch out into a different aspect, and we know that they're already a good, kind, and meticulously, scrupulously clean person, that we can ask them to train and then have them join our practice so we know that they're vetted and doing things the way they should be done.
Thank you. Well, I think if there aren't any other comments or questions, Dr. Boiko, thank you so much for that wonderful talk and discussion. And thank you everybody for attending Grand Rounds today. And we'll see and hear you next time. We can put up the QR code for a little bit longer as well.